This is the lecture for Seizures and Epilepsy, Chapter 36. So what is happening in the body? A seizure is an abnormal, sudden, excessive, uncontrolled electrical discharge of neurons within the brain that may result in a change of level of consciousness, motor or sensory ability, and/or behavior. Epilepsy is a chronic disorder in which repeated, unprovoked seizure activity occurs. Assessment findings. In generalized seizures, involves both cerebral hemispheres. It can begin with an aura. There are 5 types of generalized seizures: tonic-clonic seizures, clonic seizures, myoclonic seizure, and a tonic or kinetic seizure. In tonic-clonic, there's a few seconds of tonic, stiffening, and level conscious changes, followed by 1 to 2 minutes of clonic, jerking. Cyanosis, biting of cheek or tongue, incontinence can occur, and a postictal state of confusion and sleepiness. In tonic seizures, there's a sudden loss of consciousness with less than 30 seconds of increased muscle tone. In clonic seizures, this can last several minutes, noting contact and relaxation of the clonic phase. Myoclonic seizure is lasting for seconds with symmetrical or asymmetrical jerking or stiffening of extremities. A tonic or a kinetic seizure is few seconds of loss of muscle tone that can lead to falls, and then confusion past event is common. Partial or focal seizures include only one cerebral hemisphere. They can be simple or complex. Complex may cause loss of consciousness for 1 to 3 minutes. Characteristic automatisms may occur, so these are behaviors that the client is unaware of, such as lip smacking, and they may have amnesia after the event. Simple, the client remains conscious throughout. They often report an aura, autonomic abnormalities such as heart rate changes, flushing, unilateral abnormal extremity movement, or pain or offensive smell may be present. Labs and tests. An EEG can be used to record electrical activity and identify the origin of the seizure. CT scans, MRIs, or PET scans can be used to identify or rule out potential causes that we will discuss. And then you can test for alcohol or illicit substance levels. For seizure precautions, these are listed in page 905. With seizure precautions, you would want to have oxygen and suction equipment available, with an airway also if needed. IV access, and you want to follow your agency's policy for any more specific seizure precautions. Some may pad rails or use of side rails, and then others may discourage it. Padding of side rails hasn't really been shown to be more beneficial, or people don't really get injured because side rails are up. Priorities for a client experiencing a seizure include addressing alteration of ABCs, treating status epilepticus, and keeping the client free from injury. Box 36.9 on page 905 is care of the patient during a tonic-clonic or complete or complex partial seizure. So things like protecting them from injury. You don't want to force anything into their mouth. Turn the patient on their side. This is going to prevent any aspiration and keep their airway clear. Remove objects that might injure the patient, and suction any oral secretions. Loosen any restrictive clothing they may have on, but you don't want to restrain or stop those movements. You do want to record the time the seizure began and when it ended. At the completion of seizures, you want to assess for vital signs, neurologic checks, keep the patient on the side, and allow patient to rest. You're going to document the seizure, how often the seizures occurred, the date, time, and duration of the seizure, if there was more than one type of the seizure that occurred. Observations during the seizure include the changes in pupil size and any eye deviation, changes in level of consciousness, any presence of apnea, cyanosis, and salivation, incontinence, bowel and bladder, any eye fluttering or blinking, any movement and progression of motor activity like lip smacking or other automatisms, such as tongue or lip biting, how long the seizure lasts, when the last seizure took place, and whether the seizure was predicted by an aura, and what the patient does after the seizure, like how long it takes for the patient to return to a pre-seizure status. So assess the seizure for the ABC complications, airway, breathing, circulation, or the seizure lasting more than 5 minutes. You want to keep that client free from injury and document your assessment findings. It's not unusual for the client to become cyanotic during tonic-clonic seizures, but the cyanosis is self-limiting and no treatment is needed. Some providers prefer to give high-risk clients oxygen by nasal cannula or face mask during that post-ictal state. Nursing interventions and treatment. So for seizure control, the treatment of seizures and epilepsy is multifaceted and consists of treating the acute seizure while it occurs, treating and eliminating the cause, and preventing further seizures. So in most cases, primary epilepsy is successfully managed through drug therapy. Most seizures can be completely or almost completely controlled through the administration of anti-epileptic drugs or AEDs. Table 36.2 on page 904 is drug therapy that is used to treat seizures and epilepsy. These include hydantoins, immunostilbines, succinimides, benzodiazepines, and other miscellaneous drugs such as gabapentin, lamotrigine, topiramate, pregabalin, and valproic acid, and ezogabine. The first-line treatment for clients experiencing a first seizure or status epilepticus are benzodiazepines, such as your lorazepam, diazepam, and midazolam. Benzodiazepines can be administered intravenously, intramuscularly, or rectally. So for your drug therapy, if the chosen drug is not effective, the dosage may be increased or another drug introduced. At times, seizure control is achieved only through a combination of drugs. The dosages are adjusted to achieve therapeutic blood levels without causing major side effects. Because of these potential side effects, you want to teach the patients to follow up on any laboratory test appointments, to monitor for their CBC or complete blood count and liver enzymes, and assess for therapeutic drug levels. Most AEDs can cause leukopenia and liver dysfunction. Some drugs, especially the hydantoins like phenytoin and phosphophenytoin, can cause gingivital hyperplasia. So you want to observe and report beginning gingivital changes and perform frequent oral care to prevent any permanent damage. If possible, they should have regular dental checkups. You want to be aware of any drug-to-drug and drug-food interactions. For instance, phenytoin should not be given with warfarin and oral contraceptives. It causes decreased effectiveness of oral contraceptives and a decreased absorption of warfarin. So you want to look at that drug alert on page 906 about phenytoins. Their loading dose is usually given IV and then it will be changed to PO as follow-up after the emergency is resolved. If it's given via infusion pump, you want to give it with normal saline. Flush the line before and after that phenytoin administration. Teach the patients that some citrus fruits, such as grapefruit juice, can interfere with the metabolism of these drugs. This interference can raise the blood level of the drug and cause the patient to develop drug toxicity. So for our nursing interventions and treatments, the seizure control and surgical management. So patients who cannot be managed effectively with drug therapy may be candidates for surgery, which includes a vagal nerve stimulation. Vagal nerve stimulation may be performed for control of continuous simple or complex partial seizures. Patients with generalized seizures are not candidates for surgery. The stimulating device, much like a cardiac pacemaker, is surgically implanted in the left chest wall. An electrode lead is attached to the left vagus nerve, tunneled under the skin, and connected to a generator. It takes 2 hours with a patient under general anesthesia. The stimulator is activated by the primary healthcare provider either in the operating room or more commonly 2 weeks after surgery. Programming is adjusted gradually over time, and the pattern of stimulation is individualized to the patient's tolerance. The generator runs continuously, stimulating the vagus nerve according to the program schedule. The patient can activate the vagus nerve stimulator with a handheld magnet when experiencing an aura, thus aborting the seizure, and patients experience a change in voice quality, which signifies that the vagus nerve has been stimulated. You want to observe for complications after the procedure, such as hoarseness, which is the most common complication, cough, dyspnea, neck pain, or dysphagia, any difficulty swallowing, and then teach the patient to avoid MRIs and microwaves. Complications include brain damage and hypoxia, most commonly due to the complication status epilepticus. Status epilepticus is a medical emergency and is classified as a seizure lasting longer than 5 minutes or repeated seizures over the course of 30 minutes. Page 906 under the critical rescue says status epilepticus must be treated promptly and aggressively. You want to establish an airway and notify the primary healthcare provider or rapid response team immediately if this problem occurs. Establishing an airway is the priority for the patient's care. Intubation by an anesthesia provider or respiratory therapist may be necessary. Administer oxygen is indicated by the patient's condition. And if not already in place, an IV access with a large bore catheter and normal saline should be infused. The patient is usually placed in ICU for continuous monitoring and management. Causes of status epilepticus could be sudden withdrawal from anti-epileptic drugs, infection, acute alcohol or drug withdrawal, traumatic brain injury, cerebral edema, and metabolic disturbances. You would push IV lorazepam or diazepam over 2 minutes. Risk factors include primary and secondary. Primary or idiopathic includes genetics. Secondary could be an underlying brain lesion like tumor or trauma, metabolic disorders, acute alcohol withdrawal, electrolyte imbalances or disturbances, high fever, stroke, head injury, substance abuse, and heart disease. So for patient teaching, management, and prevention, you want to teach them to adhere to their anti-epileptic drugs or AEDs. They should know and understand their drug therapy and emphasize that AEDs must not be stopped even if the seizures have stopped. They should follow up with any blood draws. No medication should be added without asking their primary care physician. Even over-the-counter medication should not be added until they get approval from their primary care doctor. They should wear a medical alert bracelet or necklace or carry an identification card, and then follow up with a neurologist or their primary care doctor. Family education should be given to assist them during an emergency, and follow any state laws concerning driving and operating machinery. They should be taught to avoid any alcohol and excessive fatigue, and they can contact the Epilepsy Foundation or other organized epilepsy groups for any additional info. Social services could be referred for financial assistance with getting their medications, and they should be encouraged to eat a balanced diet, get plenty of rest, and reduce their stress. They can keep a seizure diary as well. Some barriers to AED adherence can be found in box 36.10 on page 906 in your book, and I listed those out already. And that is the end of the lecture. Thank you.